Zoll LifeVest is a proud sponsor of CardioNerds. Zoll has continuously improved LifeVest for over 20 years, leading to a median real-world wear time of 23.4 hours per day and an AI-enhanced algorithm that delivers zero median false alarms at 90 days. The newest LifeVest garment is lightweight, breathable, and preferred by patients for its comfort. Learn more at lifevestinnovation.com.
Worldwide, cardiovascular disease affects the lives of hundreds of millions. Dedicated cardio nerds everywhere are working hard to fight this global epidemic. These are their stories.
Welcome, CardioNerds. I'm so excited to be here with you today for another episode in our Cardio-Rheumatology series. My name is Gurleen Kaur, and I am a cardiology fellow at Brigham and Women's Hospital and assistant program director for the CardioNerds Academy, as well as co-lead for the series on cardio-rheumatology. I'm joined today by my co-fellow lead for the series, Dr. Rick Ferraro, an esteemed cardio nerd and currently cardiac imaging fellow at the University of Michigan. How's it going today, Rick?
Gurleen, it is so great to be with you tonight, as always. We are very fortunate to have another cardio nerd with here today, Dr. Jake Roberts. Jake is a CardioNerds Academy fellow and current third-year internal medicine resident at UCLA Medical Center in Los Angeles. He previously earned his medical degree at Johns Hopkins University, a place that myself and our expert tonight are very familiar with, so excited to talk about that. So Jake, welcome. I hope you are having a great day.
Thank you, Rick and Gurleen. I'm so excited to be here and can't wait to get started with this episode and learn from one of the true experts in cardio-rheumatology and imaging fields. I have the great privilege of introducing our guest expert, Dr. Monica Mukherjee. Dr. Mukherjee is an associate professor of medicine at the Johns Hopkins University Division of Cardiology and specializes in advanced cardiac imaging, currently serving as the medical director of the echocardiography lab at the Johns Hopkins Bayview Medical Center and as associate director of the Johns Hopkins echocardiography programs. Dr. Mukherjee obtained her medical degree from the George Washington University School of Medicine. She completed internal medicine residency training at Drexel University before then returning to George Washington to complete her cardiovascular disease fellowship training. She additionally earned a master's in public health from the Johns Hopkins Bloomberg School of Public Health with a special concentration in epidemiological and biostatistical methods for public health and clinical research. Dr. Mukherjee has earned multiple research awards and grants for her work on right ventricular remodeling and heart failure, pulmonary hypertension, and scleroderma, and her research continues to utilize multimodality imaging techniques to refine risk prediction of adverse clinical outcomes in connective tissue diseases such as systemic sclerosis. Dr. Mukherjee, it is a pleasure to have you join us today, and we are so excited to learn from your expertise.
Hi, Rick. Hi, Gurleen. Hi, Jake. I'm so excited to get nerdy with you about my favorite topics, cardio-rheumatology and multimodality imaging. So thank you so much for having me.
Now, I just want to jump in really quickly as an alum of the internal medicine program at Hopkins and the cardiology program there. Dr. Mukherjee was such an incredible resource, such an incredible mentor. I can't speak highly enough, and I'm so excited for this conversation tonight. So thank you for being here.
Oh, you're welcome. Good to see you all again.
Thank you so much, Dr. Mukherjee, for taking out time for being with us today. We're so excited to learn more about the role of multimodal imaging for cardiovascular disease risk stratification and management in patients with systemic inflammatory diseases. So to get us started, I want to ask you, what are some settings in which we might pursue advanced cardiac imaging in systemic inflammatory diseases? Are there certain inflammatory disorders with higher associated risk for cardiovascular disease for which advanced imaging can help guide early interventions?
There is mounting evidence of the increased cardiovascular morbidity and mortality from autoimmune-mediated rheumatic and musculoskeletal diseases. Systemic inflammatory diseases really encompasses diverse conditions that are characterized by an abnormal immune system activation. And understanding that these diseases are associated with heightened cardiovascular risk really has significant implications for early detection, risk stratification, prognostication, and then also implementing therapeutic strategies to mitigate that risk and instituting disease-modifying therapies. I would say that the most well-characterized autoimmune disease that has evaluated the link between systemic inflammation and cardiovascular disease are the inflammatory arthritic conditions such as rheumatoid. So rheumatoid, as you all know, is this polyarticular chronic inflammatory disease that's associated with markedly increased morbidity and mortality. And patients with RA have a 1.5 to 2-fold risk of developing incident coronary artery disease when compared with the general population. And this is likely due to derangements in the metabolism of lipids, endothelial dysfunction, and vascular inflammation. And then, really, across all of the other inflammatory arthritic conditions, such as psoriatic arthritis and the spondyloarthropathies, can all increase risk for incident ASCVD. But then we move to other clinical conditions like systemic lupus erythematosus, some of the inflammatory myositis, vasculitides, and systemic sclerosis, which can cause a myriad of cardiovascular manifestations beyond coronary artery disease that may involve the pericardium, the myocardium, valvular structures, as well as elevated ASCVD risk.
Thank you, Dr. Mukherjee. That was a great discussion of the elevated cardiovascular disease risks in patients with systemic inflammatory diseases. It sounds like there's potentially an important role for early subclinical cardiovascular disease detection within this patient population. As a follow-up question, can you speak a bit to any established or emerging imaging technologies for improved early detection or characterization of cardiac involvement in systemic inflammatory diseases? And are there any limitations to these imaging modalities in the context of systemic inflammation?
Yeah, so Jake, that's a great question. Really, at the forefront of screening and early detection is echocardiography, which is an essential and widely used imaging modality that can assess cardiac involvement in these conditions. Due to its widespread availability, there's real-time interpretation, low cost, and non-invasive nature. Well, echocardiography is a wonderful tool for early detection, screening, and prognostication for pericardial, myocardial, and valvular involvement in patients, especially with the inflammatory arthritic conditions who have heightened ASCVD risk. CAC score as well as CCTA are crucial to visualize the coronary artery lumen and effectively detect CAD. And this is a wonderful tool that we can use that's non-invasive. CAC score is not associated with any administration of iodinated contrast, while CCTA, we've now gotten down to a pretty precise science to limit contrast exposure. So this may be more feasible in young asymptomatic patients that have abnormal ASCVD score that you're worried may have coronary involvement. And then using radio tracers, we can also use SPECT imaging, which is the most widely used and available technique to assess myocardial perfusion during stress and exercise. And because of the high sensitivity for detecting obstructive CAD, the specificity of SPECT remains low, but can be increased when used in combination with hybrid techniques such as SPECT-CT imaging. Of course, the gold standard for testing, if any of these are abnormal or if the pretest probability is quite high, coronary angiography remains the gold standard for diagnosing and treating CAD, but should not be used as a screening tool. It's really when your pretest probability is high or you have evidence on one of these other non-invasive tests that there is a regional abnormality in myocardial perfusion.
That's fantastic, Dr. Mukherjee. I really appreciate that. And one of the things that I think you started to get into a little bit is the context and the specific inflammatory diseases and some of the emerging imaging modalities we can use to explore that. And so I wanted to ask, are there different imaging techniques that we can or should use to assess complications specific to each disease? So for example, I've learned a lot about the right heart from you. In patients with systemic sclerosis or right heart disease, is there a role for utilizing specific modalities for early detection of pulmonary hypertension or lupus, for example, or subclinical pericarditis? Are there additional examples of systemic inflammatory diseases where elevated risks of certain cardiac complications may arise? And what is the clinical utility of those various situations?
Yeah, so this is a great question. And of course, we could speak hours about the different systemic inflammatory diseases and imaging specific to each of those. We can start with systemic sclerosis, which, as many of you know, is near and dear to my heart. This is a heterogeneous autoimmune disease that's characterized by widespread tissue fibrosis across multiple organ systems, due to underlying microvascular vasculopathy and dysregulation of the immune system. And one of the issues with systemic sclerosis is that the cardiac manifestations can be quite variable depending on the subtype of disease. And it can be either due to primary effects of the fibrotic disease process, or it could be secondary effects. So, for example, interstitial lung disease will increase afterload on the right ventricle and lead to adverse adaptive responses in remodeling. And so, because there's such a wide spectrum of cardiac involvement, you really want to start with screening tools that are not invasive and pair them with clinical variables. So, in systemic sclerosis, for example, we perform yearly echocardiograms on these patients. We perform NT-proBNP. We're coupling that with yearly pulmonary function testing, and we're using all of these in concert to understand what the driver is of sometimes very nonspecific symptoms. So, very frequently, scleroderma patients present to clinic with shortness of breath, and it's difficult to ascertain what's driving the shortness of breath. Is it myocardial disease from diastolic dysfunction, which is highly common in these patients? Is it due to emerging pulmonary hypertension? And then, if it is pulmonary hypertension, what is it coming from? Is it pulmonary arterial hypertension? Is it pulmonary hypertension due to interstitial lung disease? Or is it pulmonary hypertension due to postcapillary etiologies? And so, really, at the forefront again is echocardiography. And then, once you have established what the primary driver is, you then have branch points of what is my next step in testing. Now, in terms of RV dysfunction and pulmonary hypertension, CMR is a wonderful tool to not only detect subclinical myocardial disease, but also some of the novel mapping techniques that we are using can detect low-grade diffuse myocardial inflammation. So in your systemic sclerosis patients or SLE patients who are early in their disease course and have changes in their biomarkers or persistent elevation in their biomarkers, you can really detect aggressive disease at an earlier stage. And that's something that MR offers above all of the other modalities, is the ability to enable non-invasively tissue characterization. And then CMR is also really important when you start to institute PH therapy. So you want 3D quantification of the right ventricle, which is something that we can do with echo, but we can follow in a more quantitative fashion that's not as dependent on the acoustic window when we're using CMR. So most of our clinical trials, we are using CMR quantitative metrics to look for improvements in chamber shape, chamber volumes, and chamber function. Now, in terms of SLE, it's very similar to scleroderma in that it can cause a spectrum of cardiovascular involvement. Probably the most common is involvement of the pericardium. So pericardial disease is very common in SLE, and it may be the first presentation of SLE. Again, 2D echo is the first-line imaging modality that we use when we're suspecting pericardial disease involvement. And then, you also have the addition of Doppler imaging, so you can interrogate the hemodynamic effects of the effusion. But then, as the pericardial disease may progress, SLE patients can also present with constrictive symptoms. And then you move from 2D echo to either CT or CMR imaging to define the pericardial myocardial anatomy. So really, the branch point beyond echo as a first line is highly dependent on what your clinical suspicion is and what the disease historically involves.
Thank you, Dr. Mukherjee, for taking us through the imaging techniques in various inflammatory diseases, including systemic sclerosis and SLE. It's really helpful to hear about how these various modalities fit in when we're thinking about things such as echocardiography and cardiac MRI. And now that we've identified when we might consider advanced imaging and the different modalities, we'd love to learn more about your clinical approach via a patient that we'll see here in the CardioNerds clinic. So first up, we have Jill Janeway, who is a 40-year-old woman with a past medical history of systemic lupus erythematous, or SLE, who's presenting for follow-up on joint pain. Previously, her joint pain was more severe, but she still continues to report occasional joint pain and fatigue. Her symptoms have overall been well controlled on hydroxychloroquine, prednisone, and mycophenolate. She's also taking calcium and vitamin D supplementation. She currently does not have any history of heart failure or other cardiovascular disease. So in this patient, if you were seeing her in clinic, Dr. Mukherjee, what would be your initial approach to assessing cardiovascular disease risk and inflammation in this patient using advanced imaging? What are the role of the different modalities in this patient population?
So, to start with, any patient that presents with any of the systemic inflammatory diseases should have baseline ASCVD risk assessed. And this includes standard lipid panel, A1C, as well as a deep dive into what the etiology of her fatigue is. I would go ahead and start with a screening 2D echocardiogram. As I mentioned before, SLE is commonly associated with pericardial effusions and involvement of the pericardium. So it would be important to have a baseline echo and understand if there is any pericardial involvement. And then if the ASCVD risk is elevated, there is a role in these patients for assessment of coronary artery calcification, which is a hallmark of atherosclerosis. And there's an extensive body of data that supports the value of a CAC score as a significant predictor of outcomes, even in asymptomatic individuals. So I would argue that in addition to lipid panel, A1C, I would perform an echocardiogram and a CAC score.
Wonderful. Thank you so much for that excellent discussion, Dr. Mukherjee, about the approach to utilizing advanced imaging in this patient with SLE. Now we would like to kind of follow that up more with some more discussion in terms of sort of the follow-up for this patient. So in general, is there any sequence to imaging techniques that you would consider in patients with lupus or other inflammatory diseases? And how do you decide which modality you would like to start out with based on the disease involved? What is your approach to serial imaging and follow-up in these patients, such as the one that we discussed here or others with other rheumatologic diseases?
Serial imaging would be guided in this patient based off of what we believe the primary driver of her symptoms are. So, for example, if the echocardiogram demonstrates that there's direct myocardial inflammation or acute myocarditis, diastolic dysfunction in the absence of traditional risk factors, if any of those features were noted, that would change our approach to what the next imaging modality would be. So, for example, if there is evidence of acute SLE myocarditis with associated heart failure, or if there's EKG evidence of conduction abnormalities, these patients require early and potent immunosuppression, as well as cardiac magnetic resonance imaging, which may demonstrate that there's myocardial inflammation with or without involvement of the pericardium. And so I think in these patients beyond the screening echocardiogram, I would really move towards CMR, which is a very important clinical tool for diagnosing SLE-associated myocarditis early. Now, on the other hand, suppose the primary driver of symptoms is ASCVD and she has an abnormal CAC score. So there is an elevated atherogenic risk in these patients, and that may intensify my ASCVD risk stratification and move me towards ruling out whether or not she has any signs of inducible ischemia. And perhaps microvascular disease due to inducible ischemia is the driver of her fatigue. So often these patients present with very atypical symptoms. There is some new evidence coming out about PET perfusion imaging to identify impairments in coronary flow reserve in these patients, but that is largely an investigative tool right now. I wouldn't say that it's currently first line, and a lot of expertise is required for PET perfusion imaging. But that is something else that you could consider in someone with SLE with high ASCVD risk that you're really worried about microvascular disease and heightened ASCVD risk.
Thank you so much, Dr. Mukherjee. And as you said, and as you outlined, it's really tough. I mean, there's such a spectrum of disease, really in all patients, but in patients with inflammatory diseases to an extent in particular, choosing what to use when is really tricky. And I just wanted to highlight for the audience the scientific statement that came out last year from yourself and Dr. Weber, who's also we've interviewed during this series as well as some others on novel imaging approaches to cardiac manifestations and systemic diseases. There is a graphic there, the central illustration, I should say, that is just really, really spectacular and a good reference point for anyone. One thing I did want to follow up here, though, is it seems like there is significant opportunity to utilize imaging and multimodal imaging in systemic inflammatory disease to provide early CV detection, kind of as we discussed during our case. But what sort of evidence, in addition to what we've already discussed, is there to assess the impact of treatment or cardiovascular outcomes in patients with systemic inflammatory disorders?
Advancements in multimodality imaging are really revolutionizing our understanding of the cardiac involvement in these patients. And this has really emerged in the past few years, I would say, where we are now understanding that cardiac involvement in these patients is far more common than we originally thought. And by providing precise and detailed information, imaging can really guide personalized medicine approaches and tailor treatment strategies to individual patients based off of their specific disease characteristics and response to therapy. And so I think you're right that there is no one size fits all approach. It really depends on what is the primary driver of symptoms. What is the one aspect that you are most focused on for screening? So that is why I think echo is at the forefront for screening. And then when you're talking about serial assessment of these patients, it really depends on, again, what is the primary manifestation that you are targeting with your imaging, because each one has its own benefits and limitations. If you're worried about myocardial inflammation or inflammation of the pericardial sac, that's going to be very different when you compare to someone that you're very worried about ASCVD or incident coronary artery disease or microvascular dysfunction. And so there is no one size fits all approach, but we should have a heightened awareness that cardiovascular manifestations are extraordinarily prevalent in these patients and that their risk is increased more so than the general population because it's heightened inflammation of multiple aspects of the cardiovascular system. And that can really impact morbidity and mortality. So we are moving away from a single specialty approach when we're discussing these patients. It needs to be collaborative. Not only do rheumatologists need to be more aware, but cardiologists do as well. We see so many of these patients in our clinic, and I don't think that, until I started delving into this from both a clinical and research perspective, did I understand how many manifestations these individuals can have. And it spans anywhere from the epicardial coronary arteries to the microvascular system, to the myocardium, to the valves, to the pericardium, as well as secondary involvement and adverse remodeling. So I think it all starts with awareness and then making sure that we are staying on top of aggressive disease modification.
It's such a diverse topic. We could really, and we've had a few episodes discussing this, but you could discuss exactly like you said, each of those things. ASCVD risk, you're talking about pericardial disease. Anecdotally, one of the most impressive things I've seen is interval imaging of sarcoid patients and PET, which is something that I'm spending a lot of time doing. And when treatment is started and you see a reduction in PET avidity on follow-up imaging, it's really just this striking, really cool, almost inspirational aspect to what we do. And again, we could talk about that individually for a long time, but it's pretty cool.
Yeah, absolutely. And I think that, in the case of cardiac sarcoid, which of course is its own topic, CMR offers several advantages in assessing these patients, again, providing detailed information about myocardial structure and function, tissue characterization. And then you can also use late gadolinium enhanced images to look for wall thinning and aneurysmal segments. as well as quantification of any replacement fibrosis. So I think in cardiac sarcoid in particular, MRI with late gadolinium is the preferred methodology.
Thank you, Dr. Mukherjee. I think from our discussion today and throughout our cardio-rheumatology series, we've learned a lot about how there's elevated cardiovascular risk, like you mentioned, in many of these systemic inflammatory diseases. So it's becoming even more important for us to use the tools we have to the best ability to help assess risk in these patients and to detect ASCVD early. But it's not just ASCVD, as we talked about. There's pericarditis, myocarditis, other aspects of inflammation in these diseases. And currently, there's not many formal standards of care to direct the use of multimodality imaging to assess cardiovascular disease risk and guide the management in these patients. And you also touched upon this earlier, that there's also novel imaging techniques on the pipeline, that some of them might be used for research only right now, but might be on the horizon. So I was wondering if you could talk to us a little bit about what you think about the need for more standardized approaches in utilizing imaging in patients with systemic diseases. And what is there in the pipeline for us to look out for our patients as well?
So, one thing that always excites me about cardiology is that our practice is informed a lot of the times by clinical observations. And so, the story that I will tell is that at Hopkins, we perform echocardiograms on systemic sclerosis patients routinely as part of yearly screening for cardiopulmonary manifestation. And when I first started, I was reading all of these echocardiograms on these patients, and we started seeing a lot of really subtle things like mild right ventricular enlargement, subtle elevations in RVSP, diastolic dysfunction. And then in clinic, we were seeing systemic sclerosis patients that were coming in and they were short of breath. And so one idea we had was, we're not going to send every single systemic sclerosis patient for a right heart catheterization. It's an invasive procedure. But how do we refine what we do non-invasively to figure out what's going on with these patients? And a lot of times the shortness of breath was happening with exertion. So we at Hopkins developed this hemodynamic bike protocol. And we put systemic sclerosis patients who were symptomatic and short of breath on a supine bicycle, and were able to non-invasively phenotype what the primary driver of their dyspnea was. Is it because of postcapillary disease and diastolic dysfunction, or were we unmasking RVP and coupling from emerging pulmonary hypertension? And so I think that a lot of what is happening in the cardio-rheumatology space is very similar, that we're seeing these patients, we're seeing that they have an elevated ASCVD risk, and it's changing our practice in real time. We're still learning about what the most ideal clinical algorithm is. But now we know that systemic sclerosis patients who are presenting with shortness of breath, we need to figure out what is driving their symptoms. Is it diastolic dysfunction? Is it LV dysfunction? Or is it PH? And I think that that is gaining so much attention. It has now become standard of care. And so what I look forward to in the future for systemic inflammatory diseases is moving that cursor for all of these conditions, where a rheumatologist sees one of these patients in their clinic, they notice that their lipid panel is abnormal, and it's an early referral for a cardiologist to then see this patient, get a CAC score, do the appropriate testing, and get them on the appropriate statin therapy. So I think it's very exciting to see the field develop in real time, to be involved with it in some minor way, and to develop these tailored therapies and approaches as things come to light. I can't wait to see what happens next in this space and what we discover from all of the imaging that we're going to be getting on all of our rheumatologic patients.
Thank you so much for that discussion, Dr. Mukherjee. You've really highlighted so many excellent learning points for both us and our audience today that will help guide us and our listeners when caring for our patients with rheumatologic and other systemic inflammatory diseases, especially when it comes to assessing ASVCD risk in these patients, as well as the direct complications of chronic systemic inflammation. This is such an exciting time to hear about this emerging field within cardio-rheumatology. And, I'm, for one, am very much looking forward to seeing how the field continues to evolve and develop. With so many incredible points discussed today, would you mind summarizing for our audience the key takeaways regarding the context for when we should consider using multimodal imaging to assess cardiovascular disease risk, and how the use of the imaging impacts the management and outcomes for our patients with these systemic inflammatory diseases?
Yeah, absolutely. So, as I mentioned, this is a very broad set of diverse conditions that share a common feature, which is abnormal immune system activation. And while the specific mechanisms that underlie each of the diseases, and as a result, the cardiovascular manifestations of each may vary, the common pathway centers on systemic inflammation. And so understanding that these conditions have additional cardiovascular risk, which may manifest as incident ASCVD, myocardial involvement, pericardial involvement, or valvular heart disease is really important for us to know. And using imaging techniques can improve diagnostic precision for these patients. And especially when we integrate our approach, this may lead to earlier diagnoses, non-invasive monitoring for cardiac involvement, and early institutions of therapies that may modify the disease course. And so I hope to leave everyone with the most important thing, which is that cardiovascular manifestations are very common in patients with autoimmune diseases, that we should have a heightened awareness of these risks, and that we should be screening our patients as early as possible for potential cardiovascular manifestations.
Thank you, Dr. Mukherjee. That's a great summary, and there's been a lot of pearls in this episode for all of us to learn from. I've been on a cardiovascular imaging rotation currently during fellowship, so it's been particularly insightful to hear from you today about how all of these multimodality imaging options can be utilized in patients for systemic inflammatory diseases. So before we end today, I'd like to ask you a question that we ask all of our guests on CardioNerds. What makes your heart flutter about multimodality imaging and inflammatory diseases?
Well, I don't want to be an A flutter, but I will be fluttering about imaging, because I just think it is so amazing that you can, in real time, visualize the heart, its function, real-time hemodynamics. This always excites me, especially, at the bedside when you're rounding on a patient and you can just quickly put the probe to their heart and see exactly what's happening. I will never get over how exciting that is, that you can, in real time, visualize heart structure and function. And so I just think that imaging, whether it's a simple bedside tool or some of these advanced techniques that we discussed in the scientific statement, it is so exciting to me that this is at the forefront to tailor treatment plans and medical therapies for a new and emerging group of patients that have heightened risk. And I mean, this is a different population than what we are used to seeing. And I'm so excited to see what imaging can do to improve outcomes.
Thank you so much, Dr. Mukherjee. This has been really an incredible, wide-ranging conversation. As you note, and as Google tells us, we stand on the shoulders of giants, and things have changed so dramatically. The ability to get real-time ultrasound at the bedside is something unimaginable just a few decades ago, and it'll be, a few decades from now, it'll be remarkable what we're able to do. It's really an exciting time. And so really want to thank you for being here, for your expertise, and for your mentorship really over the years.
Thank you so much.
Thank you so much for tuning in to this CardioNerds episode. The audio editing for this episode was performed by me, Christiana Dangas. I'm an intern in the CardioNerds Academy and a senior at Boston University. Check out the episode page for show notes and references. If you found this episode or the show informative, please consider subscribing to CardioNerds on your favorite podcast platform and leaving us a review. It really helps us spread the word and further our goal to democratize cardiovascular education. Finally, this podcast is not meant to be used for medical advice. The views expressed on our show and site do not reflect the opinions or policies of our employers. All CardioNerds content is planned, produced, and reviewed solely by CardioNerds. Stay tuned for more engaging conversations and explorations in our new and exciting upcoming episodes. And now, my friends, it's time to make like an S2 and split.
Hey everyone, do you dread doing your notes every day? Do you feel like you can never get ahead of charting? If you're shaking your head yes, then keep on listening, because Freed AI is a medical scribe on a mission to free clinicians everywhere. Freed AI listens, transcribes, and writes medical documentation for you. So just imagine leaving your office at the same time as your last patient. Now, wouldn't that be delightful? Freed AI is HIPAA compliant, secure, and takes less than 30 seconds to learn. Team, artificial intelligence cannot replace you, but it can do the administrative work that will allow you to spend more quality time with your patients and enhance your personal work-life harmony. So get back to doing what you love, helping your patients, and let Freed AI do the rest. Check out www.getfreed.ai to learn more.